1 hour postprandial less than 140, and some authors say less than 130, and 2 hours postprandial should be less than 120, and HbA1c target of less than 6% is optimal during pregnancy if it can be achieved without significant hypoglycemia. This point should be very clear. So how to monitor? Monitoring, so usually it's individualized. So every patient should be monitored either once in a week or twice in a week or once in 3 weeks, at least once in 3 weeks with the venous plasma glucose, fasting and postprandial. Target I told you, we follow fasting target of less than 90, and 2 hours after breakfast it should be less than 120. And SMBG is a very good thing. Only thing we should advise our patient to get good quality glucometers, because some glucometers are not standardized. So it should be very standardized. So most of the patients require in early GDM, because early GDM is it can predispose to congenital anomalies. So we should have round the clock control. So for them we give 6-point profile, 7-point profile and 8-point profile, like that. Pre and post breakfast, pre and post lunch, pre and post dinner, late evening, night 10 o'clock, and midnight 3 a.m. or 4 a.m. according to our individual. So role of HbA1c, the HbA1c has almost no role except in the early pregnancy to diagnose whether it is a pre-gestational diabetes or true GDM. The HbA1c is used, and the levels are little false, high will be more, because HbA1c, there are majority pregnant women are having anemia, and there will be increased RBC turnover. And CGMS also, in some of the type 1 diabetics, it will be useful. And but we should be beware that CGMS, it takes values from the subcutaneous tissue fluid. So we have to calibrate periodically with venous plasma glucose as well as your good quality glucometers. Coming to the management, primary goal is safe outcome, I told you already. To provide adequate calories to achieve and to maintain normal fetal growth and development, and no definite consensus guidelines are formulated, and flat recommendation will not work. So I put before you the 2 cases. One case, structured medical nutrition therapy. One case just randomized, you avoid sweets, like that. If you tell majority patients for avoiding insulin or reducing insulin, they take very less food intake, calories, subnormal calorie intake. So what happens, case 1, birth weight was underweight, those who had less food intake, baby was admitted in NICU, and on retrospective analysis, diet pattern, under eating to avoid insulin. So if you give structured diet, so baby gets good glycemic control, good weight. So typical meal plan, we should tell them every 2.5 hours. So we should emphasize on mid-morning and mid-evening snackings. And good carbohydrate, protein, fat should be there. This is pregnancy is not a time for weight loss, or not a time for either ketogenic diet or your paleo diet. So good quality fiber is very, very important. And exercise, so mild exercise can be permitted, vigorous exercise to be avoided, and high risk individuals exercise should be avoided. Coming to the medical management, insulin remains the mainstay of pharmacotherapy for GDM. However, there has been considerable interest in using oral anti-diabetic therapies, and insulin initiation, when there is severe hyperglycemia, straight away we can start insulin. Otherwise, start with a medical nutrition therapy. If it fails to achieve target, we can start with insulin. So OHAs, lot of controversies. There is a growing interest in the use of oral drugs. There are at least 3 drugs which are studied in pregnancy. One is glibenclamide, second is metformin, third is acarbose. And glibenclamide, of course, out of question, because it's many studies has it's teratogenic, and it crosses blood placental barrier, and it produces obesity in the child. Okay, so OHAs can produce macrosemia. There are many studies regarding metformin. One I should highlight about is MIG-TOFU clinical trial, which concluded children exposed to metformin had larger measures of subcutaneous fat, but overall body fat. This is a MIG-TOFU follow-up study. It concluded metformin or insulin for GDM was associated with similar offspring total and abdominal body fat percent, and the metabolic measures at 7 to 9 years, and the metformin exposed children were larger at 9 years. So with this only, our ADA has now, it's recommending only insulin. And there are long-term studies also concluded prenatal exposure to metformin is associated with the increased offspring weight, but not height or BMI. So studies comparing glibenclamide and insulin, so as I mentioned, glibenclamide should not be given at a present point of time. Alpha glucosidase inhibitor, it has been studied, and almost all the guidelines, ACOG, ADA, and IDF, they give insulin as a drug of choice. So we have to start with minimum dose of either 30-70 or 50-50 pre-mixed insulin, and if there is postprandial plasma glucose is high, we can give rapid acting insulin analogs like Aspart, Lispro has been approved. And usually women with GDM require less than 20 units of insulin only, but pre-GDM women, which is very difficult to control, they require more than 100 units of insulin, or sometimes 50 units per day, 40 units per day, like that. So hypertension should be addressed effectively from the early GDM itself. And dyslipidemia, it should not be corrected during pregnancy, because statins are having conflicting reports. Only omega-3 fatty acids we can think of, and other drugs also we should avoid. And a few words about primordial prevention of pregnancy, because it's a diabetes in pregnancy, it's a vicious cycle, mother in diabetes, infant of diabetes mother, and child or woman with diabetes. And now our Professor Dr. Sheshya is addressing in all the conferences, and his long research, it shows primordial, we can prevent diabetes at the earliest. So maternal 2-hour postprandial plasma glucose should not cross 110 milligrams at the 10th week, as fetal beta cells start secreting insulin around 11th week of pregnancy. And if you address intervening with the medical nutrition therapy or metformin with the grace period of 2 weeks, and 11th week, if it is high, sugar levels are more than 110, and after following weeks, so we should think of not enough time is available to achieve 110 milligrams. So the fetal beta cell starts secreting and increasing insulin. So hyperinsulinemia will be there. So many studies has proved hyperinsulinemia is present in the even cord blood itself. So in the embryonic stage, we should try, and if sugar levels are more than 110, we should start with metformin, which is safe in embryonic stage, is over after 8th week of pregnancy, and in the rest of the time metformin can be continued. So his aim is to produce diabetes-free generation. 2 hours postprandial should be maintained at less than 110 milligrams. To summarize, pregnancy is a state of high metabolic activity. The mechanisms involved are complex. Management should be individualized. Ultimate aim should be safe outcome without any complication. With this, I conclude my talk. Thanks for patience.
Thank you, Dr. Periyandavar. A great talk on early of time to discuss about it. I think as time is short, we'll go on to the next speaker.
I now request Dr. Sunil Gupta to talk on GDM clusters. Over to you, Dr. Sunil Gupta.
Good morning, Chairperson, Dr. Sadashiv Rao and Madam. And my today's talk is on GDM clusters, newer perspectives. And my humble thanks to the organizer, RSSDI TAMILNADU chapter, which includes Dr. Vijay Vishwanathan, Dr. Shanmugavelu, Dr. Rajendran, Dr. GVK, Panir Selvam, Dr. Bhavatarani Shanamungam, Dr. Ravindrantham. I had wonderful hospitality at Trichy with him very recently. And of course, Dr. Chandrasekhar and Dr. Arthikan and Dr. Balamurgam and everyone here. There's no conflict of interest for this particular session, and my journey for the pregnancy diabetes started long back with the blessings of Professor Sheshya, which then continued with Tamil Nadu relations have continued and strengthened further after that with my mentor, Dr. V. Mohan sir, Dr. Ramchandran, Dr. Vijay, and Dr. Anand Moses, and of course Bhavatarani and the team, and by Dr. Balamurgam and Dr. Muruganathan. All this team has stimulated me to come back to Tamil Nadu more and more, and since last, I feel this is the third visit in last 1 month to Tamil Nadu. So thank you very much, and of course Dr. Shanmugavelu. So this is the evolution of definition. If you just see, diabetes appeared in the patient along with the pregnancy, and at the very same time, while the pregnancy lasted, it lasted. As the pregnancy developed, it developed, and it's terminated soon after the pregnancy. Now this is Benevit's 1824, almost 200 years from now. It was diagnosed that is possibly it is GDM, and this was his thesis topic of Benevit's was diabetes a symptom of pregnancy. That was the thesis topic of this guy. And this was mentioned in Diabetology in 1989. This original publication, first record case of diabetic pregnancy from the University of Berlin. I feel everyone knows, and this has been repeated multiple times by Baba Tarni and also the next speaker. And then we have GDM, 2 generations are affected, and both of them can be protected by blood glucose control and early diagnosis and the treatment. And you have now the data, like you talk about DCCT in type 1 diabetes, type 2 diabetes, talk about UKPDS. Similarly, HAPO is one of the study where we talk about the importance of hyperglycemia control in pregnancy. So almost twice, if your blood glucose doesn't get control, almost twice the risk of having LGA, large for gestational age babies, increased fetal adiposity, neonatal hyperinsulinemia and preeclampsia, and 50% higher risk of having preterm delivery and the shoulder dystocia to these women who have GDM versus those who don't have GDM. And they now have come out with the HAPO follow-up study, like you have DCCT for follow-up study, you have UKPDS follow-up study, and you have your MIG tofu trial just have been shown by Perinder sir. So we now have even HAPO follow-up study, which has provided evidences regarding the adverse impact of GDM on the long-term maternal and the infant health. I will not be able to go into detail of it, but I will just tell you this is HAPO FUS study, some conclusions of this. So around 4,160 children of around 10 to 14 years of age of this follow-up. And what is the conclusion, what they said here is the association of the maternal GDM with child IGT, impaired glucose tolerance, and not IFG, was independent of the child's family history. Even if you do have family history, you don't have family history, but there is high risk of developing pre-diabetes, that is IGT. Together this data demonstrated a GDM associated an independent risk of offspring to our IGT, suggesting fetal programming may contribute to the observed association, although additional factors, example may be shared environmental factors and shared genetics not captured here may also contribute. Importantly, the study also demonstrated the risk of IGT in the offspring diabetic mother occurred with lesser degree of hyperglycemia. So the cutoff which is being mentioned, even if it is below the cutoff of the diagnostic criteria, even those patients, this IGT was seen in these children. Insulin sensitivity was also lower in the offspring of GDM mothers, suggesting that it was in the part independent of the child BMI and adiposity. Insulin resistance is an early abnormality in these children. It was also found that positive association of these children at 30 minutes, 1 hour and 2 hours, but not fasting. That means impaired fasting glucose was not the part of the pathology in these offspring of GDM mothers. Similarly, with high risk of IGT but not IFG in the as per the ADA. So isolated IFG is thought to reflect a high hepatic insulin resistance with relatively normal insulin sensitivity at the skeletal muscle. Now whereas those with isolated IGT typically exhibit insulin resistance in the skeletal muscle. That means GDM may preferentially impact the offspring skeletal muscle as opposed to the livers. Maybe that we have peripheral insulin resistance more common in the offsprings versus the hepatic insulin resistance. This is the systematic review and the meta-analysis to show that those who did not have GDM versus those who have GDM about mothers. So relative risk is very high, 1.9. Meta-analysis says GDM remained an association to 56% higher risk of future cardiovascular disease, 2.3-fold increased risk of CV event, and in the first decade of the postpartum. Now, any earlier definition was any degree of glucose intolerant that was first recognized used to be called as GDM, but then people realized this is not a complete definition. We now realize when we understand they are different, like we have heard about early GDM from Dr. Professor V. Mohan, as well as we know some more terminology which have come. That means it is not simple that any hyperglycemia, it could be a pre-existing undiagnosed diabetes. So GDM now they say diagnosed in the 2nd or the 3rd trimester. That was not clearly overt diabetes is GDM. Still I feel little refurnishing is required. These are the FIGO guidelines that you have umbrella term as hyperglycemia in pregnancy, subdivided into 2. that is GDM and DIP, diabetes in pregnancy, those who are known type 1 or type 2, or those who are diagnosed for the first time but during pregnancy but have cutoff values of pre-existing or non-pregnant state in normal individuals. So if you have that cutoff, then you call it as overt diabetes or a DIP category. So now if you talk about the different classes of or different clusters of GDM, you have conventional GDM, which I am not going to go in detail of it. You have overt GDM, overt diabetes or overt diabetes in pregnancy, and that is what pre-gestation